Thank you for having me today. I have mixed feelings about talking about burnout today. It's like, welcome to your midday talk on a Thursday about such a riveting topic that unfortunately we all probably know a little something about. Um, so my hope today is to provide a lot of validation based in the research around an experience that we're probably all having had at some point in our careers. And then also to have a discussion about what to actually practically do about it. So hopefully it's not just a downer. So my name is Cassandra Holinka. I'm a clinical psychologist here at UConn Health. I'm a faculty member in our psychiatry department. A majority of my job duties are clinical, and so I am in charge of our outpatient psychotherapy services for addictions here. I also do some other clinical work in our mood and anxiety disorders clinic, where I also have a focus on treating PTSD and trauma. I also have a wide variety of other tasks I do here educationally. So I supervise psychology interns, psychology externs. I also supervise psychiatry residents who are learning how to do psychotherapy. I teach in our medical school a variety of courses, which has become something I really love. I didn't realize how much I would really connect with our medical students here. And so all of that is kind of informing my perspective today. So how did I become interested in burnout aside from the obvious? Oh, and as an aside, I do have my chat box up here. So if you have thoughts or questions that come up throughout the talk today, please feel free to go ahead and put those in the chat. I'll do my best to look at that every now and then, and maybe we can make this a little bit more interactive. But aside from the obvious down there at the bottom of my own experiences with burnout, unfortunately, how did I become interested in looking at burnout? So I think my first dabbling in thinking about burnout from a clinical perspective was actually through DBT training. So prior to really learning about dialectical behavior therapy, I was just sort of going along in my therapy training, learning about how to do therapy with clients. And I hadn't really thought about how to address burnout in a way that was sort of integrated right into the treatment that you're doing with patients until I came upon DBT. And we'll talk about this a little bit today because I think DBT does a really nice way of addressing therapist burnout. So DBT sort of had me thinking, okay, so it's normalized that therapists and clinicians will be experiencing burnout, or at least that there's a risk, right, for experiencing burnout, and that there are actually things that we can do to address that in terms of being on a team with other providers, but then also directly with our patients. And so that sort of struck a chord with me. I also happened to look at it when I was doing my dissertation. I don't even like saying the word dissertation because it brings up all sorts of memories for me, but I did look at it in my dissertation. I was really interested in looking at psychologists' experiences with a variety of variables, and burnout was one of those. At the time, I had found that psychologists in private practice were reporting significantly less lower levels of burnout than psychologists who were part of organizations. And I guess at the time I sort of thought, that's interesting. And it's funny because at this point in my career, now I'm like, yeah, that makes total sense, right? So moving into my actual career past graduate school and all of that training, I then had the opportunity to start doing some psychotherapy with medical students as part of my job here. I was briefly on the behavioral health, student behavioral health team here. And probably not shockingly, I was hearing a lot from medical students about their mental health concerns, right? Depression, anxiety. There's significant and concerning literature about the mental health of medical students in particular, but also they were reporting significant levels of burnout and really not knowing what to do about that, right? A level of hopelessness around, there's not much I can do to change this. This sort of is what it is as part of my medical training. So that stuck with me. And then outside of that clinical role of actually doing the therapy with medical students, once I was done with that and I moved more into teaching medical students and supervising other trainees, such as residents and psychology graduate students, I noticed, gosh, all of these trainees in the mental health setting, in the medical setting, seem to be burnt out already, right? And they haven't even really gotten into their full-blown careers. But everybody seems to be talking about burnout and their exhaustion, and also other mental health concerns, right? Some people end up taking leaves from their programs. Some people are really struggling and don't even have a mentor who they can talk with about some of these concerns. And so that was striking to me. Also, I started to observe the demands as part of being in a large medical system, in particular an academic health center, right? These demands impacting myself, but also my colleagues, people with different job duties, all the way from administrative job duties to the actual clinical job duties. Everybody seemed to be struggling on some level. And so it's everywhere. It is pervasive. It starts from training and doesn't seem to really go away. And so I'm constantly thinking about, this is a problem that needs addressing. And as a psychologist, I think it's really helpful to look at the research and to utilize that and leverage that in making a case for addressing it effectively on both an institutional and an individual level. So today I really will focus more so on the institutional level, and we'll talk a little bit about why that is. But first, I just want to define burnout, right? What is it? I mean, the word burnout is tossed out there a lot. I'll hear people say, oh, I'm so burnt out. But what do they really mean by that? What are we saying when we're saying we're so burnt out? We'll talk a little bit about what does this look like in providers who are working with substance use disorders in particular? Why does this happen for us? What is it about working with this population of patients that makes us more vulnerable to burnout? And again, none of this aspect of this talk will likely be shocking to you, but I do think that there's something about putting the research together and looking at this and saying, okay, yes, right? So this isn't just in my head. This is real. Other people are experiencing this, and given what burnout is and how it happens, this makes so much sense for substance use providers. And then, as I said, we'll talk about some possible solutions. And I hope to hear from you about maybe what are some solutions that you've put into place, if any, and how those have worked or not worked, and some problem solving that people are hopefully doing. So throughout this talk, I'm going to ask you to do the very psychologist-like thing that I'm often asking people to do, and that is to self-reflect, right? How does this relate to you on a day-to-day basis, and to your organization? So the first self-reflection I'm going to have you do is just answer these questions for yourself, right? So this is a very basic Likert scale here. Just take a moment and reflect on where you are. So these questions come from a measure called the Burnout Assessment Tool, which is just one of many tools that we might use to get a number or a measure of our actual level of burnout. These first couple of questions are looking specifically at exhaustion. The next few are looking at your level of mental distancing, followed by cognitive impairment. And this measure considers these core and emotional impairment, and right, and these are sort of core symptoms of burnout. And then we also have psychological distress and psychosomatic complaints, which this measure considers secondary components of burnout. So it's important, I think, right, to actually be self-reflecting on our level of burnout in a very specific and mindful way. Unfortunately, I think what happens is we don't pay much attention to this on a consistent basis, and then all of a sudden we reach a point where these symptoms are so obvious to us that we're like, oh, okay, I'm suddenly really burnt out, right? But if we had been paying attention on a more consistent and regular basis, perhaps we might have seen and might have felt this creeping up. One potential way to do that is to use a measure like this, which we'll talk about again in a bit. So what is burnout? The formal definition here is that burnout is a prolonged response to chronic emotional and interpersonal stressors on the job. So the key message here is that burnout isn't just one bad day. I'm sure we've all had a bad day where we go home and we say to someone like, this wasn't my day. Maybe you go home and you don't want to actually talk to anybody because it was such a bad day, right? That's not necessarily burnout. The key to burnout is that it's prolonged. And sometimes in the literature and sometimes clinically, you'll see it referred to as a syndrome, right? So it's a little bit longer term. Something is festering and going on there. There are three main components to burnout, and you don't have to have all three of these to be considered burnt out, but there are three components that you could be having. So the first one is exhaustion. This could be physical, but this also could be emotional, right? The second is cynicism. So having kind of a negative attitude, and that might be directed at the job. It could be directed at the organization, other people at work. And for us clinically, this could even be directed, unfortunately, at our patients or our clients. So this is really something that we should be paying attention to. The third component is this idea of professional inefficacy. So this is when we really feel like nothing we do makes a difference. We're just being completely ineffective. And we can imagine how that feeling really doesn't lead us to wanting to do the job anymore, right? When we feel like what we do doesn't matter. Why would we want to be a part of a job like that? Over here on the right, I have some quotes, and a couple of these are from research, but one in particular was from a good friend of mine who was recently complaining about lack of staffing at her job in a substance use program. And she actually said to me spontaneously, I have to stand on my head to convince people to let me help them. And I thought, oh my gosh, this is actually perfect, not only for my talk, but what a perfect example, right, of burnout. I have to stand on my head to convince people to let me help them. Just that sense of feeling ineffective. You have to go so far. You have to go to these extreme lengths to have an effect for people. This third point, I think, is really important too about burnout, and that is that it has both personal and professional implications. We could be burnt out at work, but that doesn't just stay at work, right? This is going to have an effect on us globally. And so oftentimes when we're burnt out, we might find that other people in our lives outside of work are noticing something's different for us. I know for me personally, one good old faithful sign that I'm burnt out is that my husband at home is saying to me, what's wrong? When I get home from work. So there's a little bit of that spillover. How does burnout actually happen, right? I'm saying to you, it's not just one bad day. It's more than that. The components of our job can be divided up into these two main categories. We've got job demands and we have job resources. Job demands are those aspects of our job that actually require some sort of physical or mental effort or skill. They require something of us. They're sort of taking from us, and they're often task related. Resources, on the other hand, are more helpful to us. They give back to us in a way, right? They help us achieve some sort of goal, or maybe they even stimulate personal growth, learning, or development. And the idea here is that these can sort of constantly be in flux. These can be changing a bit, but there's some sort of balance going on between the demands and the resources at any given time. These are just some examples. These lists are not all that there are, right? These are just some examples here, but job demands, so work pressure and quotas. So for us clinically, think caseload. If you've got a really, really large caseload, that's pretty demanding, right? As opposed to maybe a time, if you can think of a time when your caseload wasn't so large. For those of us working in a hospital setting, maybe RVUs, that might be an example of a job demand, right? Unfavorable physical environments can be a job demand. So one of the clinics I work in here, we always sort of joke about it because where it's located physically, it's on the internal side of the hospital at UConn Health. And so because of that, there are no windows at all in the clinic. So if you spend an 8-hour day in this clinic with patients, you have no idea what's going on outside. And so all of us, by the end of this 8-hour day, where maybe we've gotten out, if we're lucky, maybe at a break or a lunch one time, that's pretty demanding. That starts to wear on you a little bit, right? That's on one end of the spectrum. On the other end of the spectrum, maybe you've got a physical environment, depending on your job, that's actually unsafe, where you have to worry about things like physical safety. So any of these can be a job demand. And then, of course, I think most obviously is the emotionally demanding sort of interaction with other people. And again, for us clinically, think about what we're doing with our clients, right? When you've come out of a really difficult, for whatever reason, appointment with a patient, that feels different than when you leave an appointment with a patient that you feel like qualitatively just went really well. And then on the other hand, we have some examples here of job resources. I think pay is a really obvious one, definitely a resource, money, but also career opportunities. Can we move up? Are there opportunities for us to be doing something that we love? People actually tend to do a lot better in their jobs if they can spend at least 20% of their time dedicated to something that they really love and care about and value. So 20%, that's not a ton of time, right? That's not even half of time. It's just 20%. But is that available to you? Social support is a huge resource, and this could come informally or formally. So maybe time set aside to actually meet with peers and talk through things, or just time, passing in the hallway, or time spent in each other's offices in those few minutes that you maybe get between appointments or between tasks, right? But is that available to you? Participation in decision-making is huge. Unfortunately, I think this varies widely depending on setting. Performance feedback, constructive, but also positive, right? How many of us are getting positive feedback about the things that we do right, the things that are going well on a regular basis? And then autonomy. What decisions are we just allowed to make for ourselves? What can we do on our own? So these are just some examples of demands and resources, but all of this sort of comes together to inform our level of burnout at any given time, right? So this is a visual of how this all sort of comes together. And I think initially when you look at it, it's a little bit overwhelming. But once you kind of take it in, it starts to make sense. So all the way on the left-hand side here, we've just got some examples of job demands and resources. Then you see the demands and resources here. And you see there's a relationship, right? So this is really important because if you happen to have a job where the demands are just going to be what they are, and you can't really change that, what you might want to look at is there a way that we can increase some of the resources here to help mitigate the strain that occurs as a result of having so many job demands, right? You can't change all of the things that you have to do and get done but what resources can we help bring on board, right? Is there a way to increase that social support, for example? So all of this works together. So why do we care about this? Other than the fact that it really hurts to feel burnt out, right? From an employment perspective, the research does show that burnt out employees are less productive, right? And so administration should probably care about that. And we probably care about that. I don't think it feels good when we know that we're not being as productive. I know when I go home and I feel like I had a really good productive day, it just feels better. Also, and I think this is probably pretty obvious, but burnout leads to reduced employee satisfaction. Nobody, as I said before, wants to stay at a job that leads to chronic burnout, right? Also resulting in higher employee turnover. Also, employees who feel more burnt out will also report that they feel like their health is just poorer, right? So aside from specific health outcomes, they'll just sort of globally rate that their health is poorer. They just have this sense that they're not as healthy. And that's of concern. On the patient side of things, this trickles down. It definitely trickles down. So we see that in organizations with more employees who are burnt out, they have more patient safety incidents. And also patients will start to report decreased satisfaction with the care that they've received. So this becomes a clinical problem as well. And thus, I would argue, this also becomes an ethical imperative for us to address provider burnout, right? Because if we don't care about our providers, do we care about our patients and the actual patient clinical outcomes and patient safety? What are we caring about here? And if that doesn't do it for you, if we don't care about our providers and we don't care about our patients, maybe we care about money. Hopefully we do care about those things, but it's also very costly. So let's look at physicians as just one example here. To replace a physician who leaves an organization, it can actually cost 2 to 3 times that physician's salary. Just because of the cost of having to recruit someone, the cost of onboarding a new physician, and also the lost patient care revenue. So all of the patient appointments, right, that person would have had they stayed employed there, all of that revenue is then lost. And so burnout is actually incredibly costly. And again, this is just one example looking at physicians, but physician burnout in the US is estimated to cost about $4.6 billion each year. So I say this not to harp on the money, but I think that when we find ourselves in a position to have to advocate for doing something about burnout, it's helpful to have a multifaceted argument, right, as to why we should be looking at this. So let's look more specifically at what's going on with burnout in healthcare, and then specifically for us as substance use providers. It's really hard to talk about burnout without acknowledging what's going on with COVID, right? So first, I just want to touch on this here. For physicians in particular, prior to the COVID pandemic, burnout was a big problem. And it's really hard to estimate, but about 38 to 50% of physicians were reporting at least some level of burnout, right? Now, there had been a 6-year overall decline in the level of burnout up until the pandemic. The decline was very, very small, right? And if you look at the level of burnout that physicians were reporting, or the number of physicians who were reporting some level of burnout, that was still considered crisis levels, right, by the National Academies of Physicians. Up to half of physicians reporting burnout, that's a problem. That's a big problem. So then here comes the pandemic. Now you've got an increase in burnout, not surprisingly, right? And about 50% of healthcare workers as a whole, so not just physicians, but people working in healthcare, were now reporting high levels of burnout. So not just any burnout, high levels of burnout. And now people are reporting an increased intent to leave the field altogether. This seems like a big crisis to me. because we need healthcare. When we look at therapists, right, and the impact of COVID on therapists, we know so much less. And as a psychologist, this hurts my heart a little bit. A little bit of research I was able to find on this, but really not much. So a 2023 study that the VA did on their psychotherapists, and I think this was specific to PTSD therapists, so not even all therapists, but PTSD therapists, their burnout actually increased from about 40% to 56% with the onset of the pandemic. And specifically, the more people reported stress related to COVID, and people who reported prior burnout, they were at increased risk for burnout, which I think just makes sense. We don't really know the impact of telehealth on burnout other than for therapists who reported that they were frustrated with technology, they were more burnt out. Anecdotally, I think we hear a lot, and there are a lot of conversations out there about telehealth and the impact of telehealth on patients, but also on the therapists, right? There's probably a lot of conversations that maybe you all have had or that you've observed. You know, is it helpful? Is it good? At the end of the day, having back-to-back virtual sessions, are you feeling exhausted or are you feeling okay? I don't know that we really have the research yet to make a broad conclusion about that. But I said it hurts my heart a little bit that we don't have better data about the impact of COVID on therapist burnout here. And I think that's because therapists were really responsible for sort of holding a lot during COVID. I mean, here at UConn, for example, as psychologists, we were responsible for seeing our colleagues, right? So I was doing therapy with nurses who were on the front lines, physicians who were on the front lines of COVID, people coming in saying patients are dying and we don't understand why. There's nothing we can do. We just don't understand this. And so we were sort of holding everything for everyone, but who was holding anything for us? So not a whole lot of data out there on the burnout for therapists as a result of COVID, at least not yet. Maybe it's coming. There is some data in general about the impact of COVID on burnout for substance use providers as a whole. So sort of across different types of providers here. And that is that over half of substance use providers did report feeling like the quality of their work really decreased as a result of the pandemic. And that because of that decrease in the quality of work, they were feeling some level of burnout. In particular, they felt increasingly emotionally exhausted, increasingly stressed, and didn't really feel that sense of efficacy, right? You see this decrease in personal accomplishment here. And then qualitatively, people were talking a lot about this need for increased hours worked, this shifting and changing of work schedules, which I think can be really difficult to manage. People were having trouble balancing work-life needs, difficulties communicating with clients, and then dealing with the clients, right? Clients having increased needs. Our clients already have a lot of case management needs, medical needs, and so COVID comes along and those all increased that. And so I think the substance use providers were really feeling that and reflecting on that. So that's not to say that burnout is really just specific to COVID having come along, right? But I just wanted to make sure that we acknowledged that that was real, that's a thing. So in general, though, burnout is prevalent amongst mental health providers, and there are specific factors that we know tend to increase our burnout and specific factors that tend to mitigate our burnout. And these are what we know. And so my guess is that for all of us, we probably look at these factors and we're like, yeah, that makes sense. Yes, that makes sense, right? Nothing on here was surprising to me. I don't know about you all. I do want to point out the importance here of supervision, right? So when we're not getting good quality supervision, that definitely has an impact on people. Resources, that's probably not surprising. Time pressures, balancing administrative duties. There's always too much to do, I think. So what is it about working with patients with substance use disorders that makes us so vulnerable to burnout, given those other factors that we just looked at? I really just want to highlight some of these factors. So I think by the nature of our work, we happen to end up working with a lot of legally mandated patients, right? A lot of our patients will end up in the justice system in one way or another. And that ends up bringing with it some difficulties, right? You might have some patients who are meeting with you and don't want to be meeting with you. I did my internship and my postdoc at the Yale School of Medicine's Forensic Drug Diversion Clinic. And that was a whole other experience, I think, working entirely with a caseload of patients who weren't presenting to the clinic because they wanted to stop drinking, for example, right? They were presenting to the clinic because they had to. It benefited their legal case, or it was a condition of their parole. That's just totally different work. It makes the work a little bit more difficult. You have to get creative about how you're working with people and motivating people, right? There are some ethical challenges that come along with working with substance use disorders. So one of those that stands out to me is, are we aware of what is reportable to DCF, right? If our clients have kids, for example. If somebody is in the justice system, are we giving sort of extra thought to what information do we need to be disclosing to somebody's probation officer or parole officer versus what is sort of private and kept between therapist and patient, right? These are all sort of ethical challenges that might not necessarily come up as frequently with other populations. I think this goes without saying, but the high patient relapse rates, right? This is really, really difficult. Whenever I'm talking with someone who doesn't work in substance use, they always bring this up. How do you do it? People just don't get better. I'm like, oh, that's encouraging and stigmatizing, but thank you. But I think the truth is, right, there are high relapse rates. So what do we make of that? What meaning are we making of that? And how do we keep coming back to this work again and again when sometimes it can feel like what we're doing isn't having much of an impact? That's definitely a huge vulnerability for feeling burnt out. And that specific part of burnout, that's that lack of efficacy. The high rates of co-occurring diagnoses really does complicate things for us. So clinicians will often report feeling like they haven't gotten enough training to effectively treat co-occurring diagnoses, that these presentations are really complex and they're just not quite sure how to go about best treating them. Also, what we know is that for patients with co-occurring diagnoses, treatment episodes tend to be more frequent. They tend to be longer, and people tend to come back into treatment again and again with co-occurring diagnosis. So it's just harder, frankly. Patients with substance use disorders often come with difficult family and social dynamics. And we also know that in order to effectively treat substance use disorders in the long run, it's important to involve family and social supports and to intervene there if there are issues that are contributing to the substance use disorder in the long run, right? But this is hard work. This is definitely hard work. Family therapy, family treatment, it is not for the faint of heart. I think, to be honest with you, I would avoid it if I could, because it's so hard, but I can't avoid it. Right? I can't avoid it. That would be doing a huge disservice to my clients. But it's hard work. And actually, I came across a study that said for psychiatrists in particular, the more time that they have exposed to patients and their families in particular, the more risk for burnout for the psychiatrist. I thought, That's interesting. Right? It's harder. It makes things more complex and more emotionally demanding. So perhaps getting at that emotional exhaustion part of burnout. I mentioned this before, and you all know this. I don't need to tell you this. The intense case management needs of our patients with substance use disorders. And I think my friend who said that whole spiel about having to stand on her head to get anywhere, she really speaks about this a lot. How she really just can't possibly do everything for her patients. She's trying to do therapy, but also then her patients are losing housing. Her patients don't have their basic needs met. They don't have, supplies that they need for day-to-day living. People need jobs. People have educational needs. People are trying to manage getting into a sober house, legal case management needs, whatever it is. You as a therapist or a medication prescriber are not going to be able to do all of this. So we really need a team of people. And yet a lot of times we don't have a team, or there's staff turnover that results in us briefly having a team, but then suddenly we don't have a team. So staff turnover, again, this is another thing that's really hard to estimate, but the research puts it at somewhere between 28 and 74% of a turnover rate in the past year for substance use staff. So that's a wide range. And again, very difficult to estimate, but that's a big problem, right? Just when you think maybe you have enough people, someone's leaving, and then you have to absorb the job duties of somebody else. Or then you're told, well, actually, because of budget cuts, we're not going to replace this counselor or this case manager or this peer specialist. Or this admin support. And so you'll have to do those jobs too. Which when we're dealing with patients with substance use disorders who already have such high needs, for us to have to take on those duties really feels like a lot. It may be an impossible task. So there's some literature, I think specifically, right, about burnout and working with patients with opioid use disorders. Interestingly, 70% of providers report experiencing some sort of negative emotions when working with patients with opioid use disorders specifically. And 19%, so nearly a fifth, mention the word burnout specifically when they're talking about patients with opioid use disorders. And in fact, the more contact, so the more time somebody spends with their patients with opioid use disorders, the more burnout they start to report. And in interviewing people, three main factors started to come out when looking at why is this burnout happening. So this is what providers were talking about. Not having enough knowledge or training. So sometimes we're seeing that providers are sort of tossed into these roles of trying to provide services to patients with opioid use disorders without really having enough knowledge or training or feeling confident in their knowledge or training. I think some of this comes out, as I was saying before, specifically with additional training needs, such as how to treat co-occurring diagnoses, right? So it's not necessarily just, well, how do I treat opioid use disorder? But also, how do I deal with all of these other needs that come along with treating someone with opioid use disorder? Also, providers started to report having inadequate resources and partnerships in the community impacts burnout. So again, not having enough resources, right? So job demands are high when we're treating people with opioid use disorders. And if we don't have enough job resources, including community supports, people to refer people to, then you're going to see that burnout starts to go up, because then we're expected to try to do it all. And then the third thing people were reporting was not enough context to really understand what they called problematic patient behaviors. So what are problematic patient behaviors? These were things like patients not showing up for appointments, patients kind of going missing, patients relapsing in spite of the provider feeling like they had a really good plan moving forward with the treatment. And so I don't really love the wording there, but that's essentially what they were talking about. So when we as providers don't have enough information about our patients and what's going on in their lives, we don't really have enough training to understand why does this happen, we can really start to think quite negatively about this, right? And so you can start to see that component of burnout, the cynicism, that negativity creeps up, and then also perhaps that lack of efficacy starts to creep up. I'm doing everything I can, but yet, this person misses all these appointments, or they drop out of treatment, or they keep relapsing. So there's just not enough information to really understand what's going on. Also, interestingly, there's some information that there could be some particularly negative feelings toward mothers specifically with opioid use disorder. And specifically that there tends to be more provider and clinician concern for infants, right? Rather than the maternal well-being. This was particularly true for nurses. I looked for more information about clinicians as a whole, and there really wasn't that much. And so this is something I'm interested in looking at further, because I suspect that this may be true for more than just nurses. If we think about the way that society looks at mothers and the expectations that we have of mothers, I suspect that this might generalize a bit, to other professionals beyond just nursing. Right. So we might have to look at this a little bit, but I thought that this was worth noting. And maybe we can ask ourselves, when we have a client or a patient who is a mother with an opioid use disorder, what are the types of thoughts and expectations that we start to have? And sort of going back to, again, the risk for burnout being negative thoughts, right, toward unchecked negative thoughts toward our clients and our patients. So this was just a qualitative study, and I thought I'd put this in here because I think some of these are probably relatable. These were substance use counselors surveyed in both rural and urban areas. I thought these really spoke to some of the burnout that people were experiencing, right? One person sort of talking about that aspect of initially feeling like, I think this person's really got it. But saying that that's actually a trap that they shouldn't get into, because then the person goes and does something like robs a store or maybe gets shot to death. That just sounds terribly disheartening, right? To actually consider feeling encouraged, a trap. Another person talking about not being able to clear their head when they're sitting with a patient and to not really be present with someone. And this question about, are your efforts really doing anything? So now that I've uplifted you all, but probably just kind of confirmed what you know and experience on a day-to-day basis. What do we do with all of this? Like, how do we intervene with something that feels inevitable in a lot of ways? What do we do? So I want to at least acknowledge, right, that there are some individual strategies for dealing with burnout. I don't want to say that it's all institutional and systemic, and that I think we do have an individual responsibility for monitoring our burnout and responding to our burnout. but I consider these to be honorable mentions. I think that these can really only get us so far if we're not working in an institution or a system that is supportive of these and that is willing to look at how the system perpetuates burnout. So this comes with that caveat, but I do want to talk about this for a moment. So mindful self-compassion really just kind of pervades everything I do with my clients. I think it's really, really helpful with a lot of our clients with substance use, but I also think that it's helpful for providers. And there's some research on how healthcare providers specifically can use mindful self-compassion practice to help reduce their burnout, right? So if anybody is not familiar with mindful self-compassion, Kristen Neff is a psychologist, and you can go onto her website, the Center for Mindful Self-Compassion. I highly recommend her website. Not only does she have research on there about all of the ways in which mindful self-compassion is helpful, but she also has a bunch of guided practices on there that you can try out and see which practices tend to be more helpful for me, which ones do I like. And I'm constantly sharing that with patients and with other people. But mindful self-compassion really has three main components. And the one is just a mindful noticing of what's going on in that moment, whether it's suffering, whether it's, some sort of pain or a difficult experience. So in this case, I'm saying we have to mindfully notice our burnout, however that's manifesting for us. The second component of mindful self-compassion is to just sort of remind ourselves that this is a universal experience in some way, right? Suffering, experiencing some sort of negative emotion, pain is part of being human, and that all humans will experience pain at some point on some level. It might not be in the same exact way, but that there's universality in that. And the third component is saying something that's explicitly compassionate to ourselves. There's a lot of negative self-talk that goes on in our brains. I don't think I'm the only one who has a pretty harsh inner narrative at times. We can be really difficult with ourselves. And so to really have something that we can say to ourselves that's a little bit more encouraging and compassionate, right? It could be as simple as, this is temporary and you'll get through this. It could be a little bit more active, like, come on, you've got this. Like, you can do this. Let's get through it. Whatever is genuine and helpful to you. But I highly recommend exploring the website and, practicing the different types of practice that she has on there and finding what works best for you. The second bullet point here, in terms of individual strategies that tend to be effective, there's research to support that CBT-based interventions can be helpful in helping providers mitigate our burnout. So specifically looking, though, at communication skills and relaxation training. So these are skills that we're teaching our patients, right? We teach this stuff all the time, but can we flip it around and learn it ourselves? So who are we using these communication skills with, right? Do we need to set limits with other people, or do we need to ask someone for help with something at work? We can try. And are we doing the relaxation methods that we teach to our patients ourselves, or are we just doing the thing where it's like, well, this is good for you, but not for me? So we can actually do some of this training ourselves. And then the third point here is, similar to these other points, but really focus on improving gratitude, finding meaning, and reducing what's called the negativity bias. I kind of think of this whole third point here as retraining the mind a bit. The human mind is pretty negative, right? There's a bias toward anxiety and negativity. And I think this is rooted in survival, but it's often unhelpful. And so across the day, what tends to stand out in our minds? All the things we did wrong, all the people we weren't able to help, that patient who relapsed, right? But I think that we can really practice to remind ourselves of the small wins, no matter how small they are. We might need practice identifying the wins, but we really have to retrain our minds, right? It's not all negative. And a regular gratitude practice could also help with that. So this might take some time and some practice and some trying out what works well for you. And these can help. That said, they're honorable mentions. I also, as I said in the beginning, with my interest in DBT, I do want to say that I think DBT does a lot of things right. DBT kind of lays out there on the table, like, yeah, when we're working with patients who, are clinically complex and have a lot of needs, we are at risk for burnout as providers, and we have to do something as part of the treatment to deal with that, or else the treatment isn't going to be effective. And so I'm not saying that we have to do DBT with everybody, but I'm saying I think we can learn a little bit from how DBT approaches this, and decide what might we take from this, right? So interestingly, DBT clinicians practice what they preach, right? We as DBT clinicians are using the same skills that we're teaching our patients. And there actually is evidence that for DBT clinicians, increased DBT skills use reduces their burnout. So the more that we're using our own skills, maybe the better off we'll be. DBT sees treatment as a community of therapists treating a community of patients. So you're never alone. And that really gets at that social support aspect of mitigating burnout. You are not alone treating high-risk patients. That is just a recipe for disaster and for burnout when you feel alone treating high-risk patients. We should not be alone treating high-risk patients. There's an explicit checking in with each other about burnout levels. So in DBT team, consultation team, people go around rating their burnout. And then, you figure out, who do we need to check in with and problem solve? What's going on with you? What can be done differently here, if anything? Or maybe it's just providing validation. I don't know, right? But we're laying it out on the table and giving it some airtime. DBT has a really nice way of explicitly targeting what are called therapy interfering behaviors on the part of the patient and the provider. So rolled right into the treatment is behaviorally identifying whatever's going on with our patient that's getting in the way of them participating effectively in the treatment, whether it's no-showing, whether it's being untruthful in the sessions, whether there's some other interpersonal behavior that's going on in the treatment. Yeah, we're saying this is a problem. And we think that this is getting in the way of probably not only therapy, but also life. And so we want to track this and figure out what can you do differently. I think that's really helpful and can also help reduce burnout, right? Because then we're doing treatment more effectively and we're having an impact. You're seeing change. And then also, I think what DBT does really nicely is that there's this just general acceptance that each clinician is going to have different personal limits. And that's okay. And that our personal limits may actually be communicated to patients with what we call radical genuineness. We can actually, Marsha Linehan, I think is an interesting person. And if you watch her videos of her communicating to her patients about what she needs her patients to do or to stop doing in order for her to work with them, sometimes it's a little bit jarring. It's like, well, I don't know that I could say it like that. She's Marsha Linehan. But I think the premise still stands that we can talk directly with patients about what we need from them in order to effectively work with them. And in a lot of ways that can help reduce our burnout, right? If somebody's doing something and that's just crossing a line for us, it's making it hard for us to work with them, we can have a conversation about that. And if this is something that we've never done, maybe getting some supervision in how to do it would be helpful. These are just some clinical pearls to think about, informed by DBT. So we've got individual strategies. We've got some examples from DBT about clinically, maybe what could help with burnout. I really want to make the point here and work on wrapping things up by looking at systemically what we need to do differently, because this is the most important part. Burnout is not just an individual issue and responsibility. If we treat it that way, we are going to fail. We're going to fail. The research also really shows that clinicians largely prefer and will rate most important interventions that are done on a systemic level. People are not saying, yes, these wellness champions and these wellness committees are what's doing it for me. That's really helping, right? Yes, give me more trainings on how to be resilient. That's not helping. I mean, maybe you could get some nuggets out of that, right? It's sort of what we're doing here today. But that's really not what's going to make the significant difference. What clinicians are saying helps is all of this stuff on the left-hand side here. So what does this actually look like in practice? We need to improve staffing. And I think who we're hiring should be a conversation at least with who we already have on our staff, right? When people in administration are the only ones making those decisions, sometimes it leads to hiring people who maybe we actually didn't need. And we're not hiring the people we could really use. Granted, I understand that sometimes it's more complicated than that. And there might be some financial justifications that are happening in terms of why we can hire certain people and why we can't hire others. I know that. I'm advocating for conversations, right? And to get the feedback from staff about who do you need? Increasing control over workload and scheduling. This is huge to the extent that you can, right? What kind of control do people want and how can you make this happen? A big one is the acuity of our caseloads. If you have a caseload of 60 people and all of them are incredibly high risk, and you're worried about every single one of them dying this weekend, that is too much. Do you have the capability to say when you've got a new intake, gosh, my caseload is really full of really high acuity patients right now. Could anyone else take this patient? And maybe I could take someone else instead, right? Or is there any other kind of problem solving that you can do to kind of increase that flexibility and the control in that way? Do you have the ability to take breaks without interruption? I almost couldn't say that without laughing, actually. When is the last time I took a full break that was just a break? I'm not sure. So I feel a little hypocritical. Working on it. It's a work in progress, right? I know that there are all of these issues that occur here, but I think we really need to normalize taking breaks. We need to normalize that. Are all your meetings during lunchtime? Is there any other way? Is everyone clear on what constitutes an emergency, right? If administrative staff are taking a phone call and it's a patient, and that patient's like, I really need to talk to Dr. So-and-so. Has there been enough training on what constitutes an emergency where Dr. So-and-so gets pulled out of their break versus what's not an emergency and when the patient can wait? Time spent on documentation is huge in the burnout literature. Part of this is increasing with electronic health records. There's a lot of clicking going on, and actually sometimes it's as simple as just reducing the number of clicks that need to be made, as ridiculous as that might sound. But of course, I think we all know, like, time spent on notes can really just get ridiculous. All right, we're balancing all of the requirements of documentation with the time that it takes. Are we having conversations about this, though? Is there feedback from clinicians about the documentation? And is this being heard and utilized in changing documentation? Is that possible? Reducing time spent working unscheduled hours. Do we have a sense of how many people are working during unscheduled hours? Like, do we even know? Are clinicians talking about how to generate solutions about this? And then increasing resources to support new to practice clinicians. This is super important, particularly with reducing turnover as a result of burnout. So I said this before, but there's a need for good quality clinical supervision in particular, right, around things like how to deal with the complexity of co-occurring diagnoses, right? There's risk involved with that negative attitude toward patients. We need to be creating a good open atmosphere to talk about this sort of thing, to normalize it, but then to be able to talk about it. Because when it goes unchecked, there's risk there. And then as we saw, I think there's a need for more opioid specific training needs, right? So can we increase our resources specifically for new to practice clinicians? But probably throughout, right? We don't want to leave anybody out, and we don't want to assume that just because somebody's been practicing for 10, 20 years that they're okay. So beyond that and what we know just sort of generally from the research, I think it's really important that we're also getting specific assessments of what's going on in our environment, right? Because we can look at all of that and say, yeah, I think that applies, or maybe that doesn't really apply to my organization or to my work unit, or to the therapists here. But I think getting an individualized assessment is the most important part here, right? Highly recommend reading this article. Some of the larger organizations are doing some good work on this, right? In terms of reducing burnout and increasing engagement. You can kind of think of employee engagement as a little bit of the opposite of burnout. The Mayo Clinic in particular has been really active in this way, really thinking about how do we retain our employees and how do we keep them happy and less burnt out. So they published this article in 2017, and they really laid out these 9 different strategies to help their employees feel more engaged and less burnt out. These are the 9 strategies here, but I really want to focus on number 1 and number 3. So I'm making the case for acknowledging and assessing the problem. And then number 3 here, which is developing and implementing targeted interventions for burnout. So we have to acknowledge the problem of burnout, right? And this doesn't mean that we're just letting employees sort of whisper about it to each other in passing, or, you know, go out after work and talk about it there. This means that right from the top, administration should be openly acknowledging we have a burnout problem. We can assume we have a burnout problem. Maybe we don't know the extent of it, but that's what we're interested in finding out. So these dialogues should really be open and candid. There should be a lot of them, and they should be varied in format, right? So it shouldn't just be a one-off mention in a staff meeting. How's everybody doing? Anybody burnt out? Good? Okay. No, that's not enough. There needs to be a systematic way of assessing how burnt out are people in your workplace, because we know that we actually measure what we consider important, right? I bet that every organization is measuring their income, and it's probably because they consider it pretty important. So I think that we can measure burnout, and that's really how they're going to show we take this seriously. We consider this important, right? In measuring the burnout, we can compare it to national data, or we can just kind of look at it within our own organization across time. We might, if we are feeling fancy, even correlate it with other measures. So we might collect data about patient satisfaction, patient safety issues, other clinical outcomes, employee turnover, right? If we're interested in looking at, is burnout in our organization impacting or at least co-occurring with these other aspects. These are just some examples of some standardized measures and perhaps some variables that people might be interested in looking at. So there's burnout specifically, right? The Maslach burnout inventory is kind of the big one. in terms of measuring burnout, and they have some specific versions of it depending on setting and population. But there are also these other variables that you might be interested in looking at, right? You might be interested in looking at stress or perhaps overall well-being, professional fulfillment. So it just kind of depends. What do you want to know about your employees? And then once you have that information, at least as a baseline, what are you going to do with it? Well, in terms of what the Mayo Clinic did, they identified particular units or groups of focus, right? So they weren't looking at the entire organization. That would have been a pretty overwhelming task. If you have a small organization, I think that might be possible. But if you've got a larger organization, you might just want to look at specific units that are the most in need. So you might say, okay, we're going to look at units that have high burnout and low satisfaction, or you might look at specific groups of people who happen to be above or below the national means, right? So you just want to identify, how am I going to determine who we're intervening with here, right? We just want to help the people in need, is all. And then we want to elicit specific feedback from those people. And this is really important. It cannot be that administration is saying, you're burnt out. Well, I have some ideas about how to fix that for you. Because how effective is that really going to be? I think really what that does is it disempowers people further, right? And what we want to do is empower people more, give them a say, because as we've seen, giving people a say in what happens actually helps mitigate burnout. So why not bring them in about how to fix their own burnout? So we want to talk with people, right? In different formats. It could be anonymous surveys. It could be, group talks. It could be one-on-one talks. I mean, I think the best way is to do it in many different ways. That way you're capturing, hopefully, some way that everybody feels comfortable disclosing this information. People will feel comfortable in different modalities, right? Through that information that you collect, identify the greatest 1 to 2 concerns. You're not, as an organization, going to be able to address every single concern that people report. It's just not going to happen. And that's got to be normalized from the beginning, right? We want to help with the top 1 to 2 concerns. From there, then you think about, okay, what can we change now in the next 2 to 3 months? This isn't like, what are we going to do in 5 years? Because then people feel hopeless and like nothing's really going to change. But what are we going to do in the next 2 to 3 months? What can we implement now? You make those changes and then you monitor the progress. So you collect more data. Does this actually have an impact on people's burnout? Is what we're doing working? And if not, then you change it as needed. Collect more data. So this is a cycle and it goes on, right, until you see the impact. But the most important part here is that you're eliciting the actual feedback of the people who are burnt out. So I just talked at you a whole lot, a whole lot. What do I want you to know and think about moving forward, if anything? As you probably took your lunchtime to sit here and listen to this talk. I want you to remember that addressing burnout systemically, not just individually, is actually an ethical imperative. Since we know that burnout impacts our patients, not just us as employees, I think that's important enough, but it also impacts our patients. This is part of providing ethical, good quality care, right? I also want us to highlight and just validate for ourselves that by the nature of our work, working with patients with substance use disorders, we will face unique challenges which contribute to our risk for burnout. And that just makes sense given what we know about what increases risk for burnout for clinicians. I want us to think about the need to assess and intervene with burnout in an ongoing and individualized manner. Sure, we can try to throw what we know at burnout and see if it helps. But really, if we're going to have a significant impact, we have to know specifically what's going on in our organization through an assessment. An assessment is what really kind of denotes, yeah, our organization cares about this. And in the end, everyone really benefits when clinicians are less burnt out and more engaged at work. Obviously, we benefit, our patients benefit, and I think administration benefits as well, right? They don't have to deal with the turnover and the costs, and everybody's just happier. So it's win across the board. That's what I have to talk to you about. I'm curious about your thoughts, questions, observations. It looks like we have a little more than 15 minutes left here. So I'm going to stop sharing my screen. And open it up.
I have a question,
Yeah.
Cassandra. I'm wondering if there is any evidence or any advice on how to successfully communicate this with an administration. Because I think, you know, and I'm being pragmatic with how I'm communicating, but I think there are some points that you touched on that I think a lot of folks probably really identified with. But I'm just wondering if there's any evidence, like I said, or any advice or guidance on how to kind of promote a better understanding of this at a level that is not kind of at the ground.
Yeah, I think that's a really important question. I haven't come across empirical data on that, but what I will say is that I think we're usually, and other people feel free to jump in here, but I think we're usually more effective at making an argument for something or advocating for something when we can explicitly show the other party how it benefits them. And so I think coming into a conversation, you know, genuinely and vulnerable and saying like, yeah, this is absolutely how this would benefit me. And also, here's how I know it would benefit you as well. So can we talk about this? Can we figure out a next step? And that's why I think I wanted to also highlight, you know, as weird as it feels for me as primarily a clinician and not an administrator, how I wanted to sort of highlight there's actually like cost to burnout and like revenue lost when you've got an organization where people are burnt out and leaving and not as productive. Because I think that's something that we can actually use with administrators and say, well, you know, if you don't, I mean, I wouldn't say this explicitly like this, right? I wouldn't say, if you don't care about me and you don't care about my patients, maybe you care about the money. But I think I'd find, to borrow your words, a pragmatic way of sort of presenting it in that way.
I completely agree with what Erin was saying, and I had several thoughts that I'm processing myself during this. I thought you did an excellent job, Cassandra. I just wanted to say that first. And I also want to express my sincere gratitude to the 2 administrators that joined this meeting today. I think that was important for them to be here for this.
I'm so glad you pointed that out. Yeah.
I agree. That thought came, I don't know what I've done here. Hold on. Okay. Yeah.
Hi.
That thought occurred to me when you were talking about that. You know, it's always hard to know in advance of these trainings that we get exactly who it will be most helpful for, et cetera, kind of thing. But a lot of it, what I heard was definitely a message that administration needs to hear. And that's the first thing I did is I went through all the little names on my screen to see how many were here. So unfortunately not as many as I had hoped, but some were here. So that was good. And maybe they'll pass the message on.
Yeah.
And I got to say, as heading up the wellness team here, this brought a lot of attention to what we try to do here. And as part of administration, one, I want to, first of all, as Caitlin said and Aaron said, I really want to thank you. I thought this was very informative, it made us realize, it kind of validated things that we already know, but yet gave us real simple thoughts on ways that we might be able to mitigate it. And believe me, what I want to ask first, can you share these slides with me? Okay.
Yes, I'd be happy to share.
I would like to share these slides with others. So if that's okay here in administration, I think that would be a good thing. And, I just think your information and the message you brought to us is very important.
Yes, I'd be happy to share. I
Thank
think it's
you.
always challenging, right? I mean, I think it's interesting. Clinicians and administrators, they might have different goals, but some of the goals may very well be the same. And so sort of trying to find what are those same goals, to sort of put those out on the table might help us relate a little bit more. I think staff retention, for example, should be one of those goals. I mean, I think it's really hard on clinicians when staff are leaving, when staff are burnt out. I've seen staff have to take personal leaves for what I suspect may be burnout related. I don't know, it's not my business. But it's just, that's something that we should all care about. It impacts all of us.
So let's see.
Oh,
I just want to bring up a point that I really did appreciate your presentation. I'm assuming I'm one of the people that were considered administration. But, again, I'm a clinician at heart. I've been in the field 30 years and started off as a case manager walking the streets of Middletown, Connecticut. So I understood what you were saying about our caseloads, the acuity of our caseloads. And I had excellent supervision today with one of my clinic soups today. Gabby and I talked about, connecting with clients. And I do think that I want to be mindful that we don't separate out administration as if they're bad and wrong. Administration is actually the ones that created the opportunity to have this topic brought up in a forum. So it is something that we all value. And several of our administrators, if not most, of the clinical administrators have been clinicians, have been interns, have been clinicians throughout their career. I think not to kick the can down and talk about blame, but administration here at Root Center, I think a lot of the burnout is related to not being able to fill our current positions. So I'll be in meetings where we talk about clinician burnout, clinician feelings of overwhelm, and there's actually positions that Gina and I and Ginny are trying to fill. And if I could fill those positions, we will expand our quality of care, will decrease the stress level on our clinicians, decrease caseloads. So, we're trying to build a robust internship program so that we have more colleagues to bring into our agency. So I just wanted to make sure that a talk like this doesn't further divide or separate administration from clinical, because like I said, most of us in administration really do care about our staff. And again, we're working really hard to fill our positions, which I think is the major obstacle.
I definitely appreciate what you're saying. And I think that's a really important point. If there is divide, I think that then further increases the risk for burnout, actually for both sides, right? I didn't even really touch on burnout for administrators. I mean, I'm sure administrators are feeling their own sense of burnout. That could be a whole other talk. But I think a lot of what you just said is really important, and you're doing some really, really effective things in there. And that is having these talks about burnout. And, you also mentioned like how to connect with clients. I mean, that's such an important part of mitigating burnout and making sure that we're, addressing some of the issues that tend to come up for us in the substance use world. Sometimes we end up feeling disconnected, detached, Maybe we can't relate, or maybe we're just tired and we're feeling cynical, right? I mean, you're doing a lot of things that you're supposed to be doing that are effective, and that are so helpful in this world. So I definitely appreciate you sharing all of that.
I do want to share that as an agency, we did bring on another director of operations. So we're up to 2 now. So Gina and I split 10 clinics now. About a year and a half, 2 years ago when I got here, it was just me traveling around to 10 different clinics. And the biggest thing I felt was I wasn't influential for my clients or for my staff. So now that I only have 5 clinics to go to, I'm starting to sit in on open access groups. I've covered as an open access counselor. I have sat in on individual sessions with clients and staff to help teach, coach, and mentor, but also understand the process fully. So that's how over this last 6 months since we added that extra piece of administration, how I'm hopefully turning it into administration, really understanding and being part of team meetings and huddles. So I'm hoping that the staff will start to see change. I see some of my Norwich staff smiling in the background, and I've become very close with some of the team members now that I'm able to spend more time. So that was due to administration recognizing that one clinic director of operations could handle or be influential over 10 sites throughout Connecticut. So again, I want to give credit where credit's due.
Yeah.
So I just want to point out, I know my intention was not, and I can't speak for anyone else, but I don't think there was any intention of splitting or like putting blame on anyone. I know that I myself, and I feel like Caitlin kind of was following up, was more so just looking for tools to utilize and being able to better have those conversations. I don't think anyone is doubting any of the interventions that have been made over some time, but I think there are still some feelings remaining about just the general day-to-day functions. And so just more so looking for tools and guidance as to how to have those conversations, despite maybe even knowing that other things are going on. So I do just want to point out that the intention there was not to bring up blame or cause separation between, who's got boots on the ground and who doesn't.
Yeah, no, you always ask very insightful questions, and you're courageous by coming up with these comments and concerns, and have come to value your feedback. So I didn't take that as a defensive, but it's very rare that I'm part of a meeting with 50, 60 people. So I thought this was a great opportunity to share what's actually been done the last 6 months. So again, I just wanted all the staff to be able to hear it directly from me.
I'll say too, from my perspective here, I don't know that we have the opportunity to have so many administrators who have the same experience as our clinicians, right? I mean, there's probably a lot of diversity amongst our administrators because we're working in a larger hospital system where people are coming with different educational background, different medical specialties, right? And so certainly I think, for us, for example, a lot of administrators might not understand psychiatry. They're like, what is this? What are you doing? And we're always sort of having to explain, yes, this is psychiatry. And so that can get really difficult. And so I think it's really wonderful when organizations have the opportunity to have administrators who have clinical backgrounds and or have administrators who are willing to say, let me check this out. Let me actually see what's going on here. Let me get involved. Let me sit in. Let me look and see what happens in these meetings, or that investment. It doesn't always happen everywhere. And when it does happen, I think that's really special, and that's really important.
Okay, so I've been waiting for a minute and everyone keeps jumping in. My hand was up, so now I'm just gonna go because we only have 5 minutes left. So, hi everyone. Cassandra, this presentation was so on point. I don't even think that you can fathom how on point this conversation was. Specifically, one of the slides that you had that said clinicians' preference for addressing burnout. What I really loved about this particular ground rounds is that it actually got me to pause, because if I'm being honest, usually when we're doing ground rounds, it's in the background and we're listening, but we have so much work to do that we're actually still typing, doing notes. And you started talking and I was listening. I was like, wait, hold on, let me save my work and let me like really get involved in this. So that I really appreciate. I understand where Bill is coming from. I really appreciated what Erin said. I really appreciated what Caitlin said. And it was just like, it was a wrap up of how everyone is kind of really feeling, not the division part of it, but they're like, okay, if everyone keeps leaving, then, you know, at one point here at Norwich, we had 130 clients. It was like unreal. So burnout wasn't even a word. We kind of like needed a new word because burnout, it was just a joke. But I really appreciate this because it really takes it from the clinician point of view on how we need to effectively, as clinicians and as the administrative team, work together so we can stop the high turnover, so we can stop the repetitive, you know, conversations over and over. It just seems like it's about 2 years since I've been here. It's kind of been about the same thing. So I just wanted to say personally from me, I love the fact that you got me to pause from doing my work to actually listen to what you were saying, because this was a very, to me, I can't talk for everyone, but to me, this was a very important and much needed conversation. And I'm glad that there are administrative personnel on here. It's not a personal attack. It's just when we're the same way we tell the clients, if they are open and honest with us, we get a lot further. So if we are open and honest with the administrative team, with HR, and they're open and honest with us, Bill being on here, being able to share some of the things that they're trying to do to fix the problems that we don't know about, it really just is that open communication. Because if we're left in the dark and it's just seen as we're just clinicians or we're just MMTP counselors, but we're really the boots on ground, that's where the division starts to grow, because it's like we're saying all these things and no one is hearing us. So if we didn't hear him say that they are putting things in place and they're trying to do this, then it would just it would just be the same thing over and over. So I just really appreciate this grind rounds because this was so on point. I just can't even begin to explain how this in itself was validation. How you get in that mode and you're like, I must be crazy because I'm feeling this and I'm feeling that. And this was like, oh no, it's kind of spread across the board and it's happening in other agencies and so on and so on. So I really appreciate that you guys put this one together, and I'm so glad that you presented it because the slides, the presentation, this was amazing. This is exactly what I needed today.
Thank you, Samantha. I really appreciate that feedback.
You know, Cassandra, I also wanted to say one of the things I liked about your presentation is when you're having a difficult day or difficult week or month or year, whatever it may be, thoughts are going through your mind about how it could be better or what's going on that's making it so or whatever. But one of the things I liked about your presentation is you brought up a lot of those topics and then put them together in like a group. So you realize, yeah, that's one of those things. And it's like running in the background or et cetera. So for example, thinking about how COVID has impacted us and having to like learn all new technology in like 2 minutes and bang. And then also harm reduction is kind of not for everyone here, of course, but for me, that's a new concept. I've been here for years. So it was right around the same time. So we had to deal with really two different learning experiences, like changing your thoughts from an old way to a new way. And that took time and experience and feedback. And then on top of that, it was just really, you did your work because it was clearly there. And I appreciate that. Thank you.
Thank you.
Cassandra, I wanted to say thank you too. I think that was a wonderful presentation. Burnout is just, it's so important and we need to talk about it. I mean, it folds into how our patient outcomes, our employee engagement, our turnover rate, everything. And I think, the quality, basically quality, we want Root Center to be, to give quality care to our patients and to be a great place to work. And so we need to be focusing on burnout very, it's got to be front and center. And I liked your suggestions very much. like the DBT stuff, the things like looking at documentation, okay? Some of the, you know, the time that we, like, that's like a passion of mine, the time that we waste, you know, doing this stuff that's got to be done, that's already been, you know, written in 10 other places, like that kind of, you know, that kind of stuff. And the other thing is like what Bill was talking about with quality supervision. So I think that is huge. Like, I know when I get to connect with staff and talk about what's going on, I just end up feeling energized and hopeful, you know? And, you know, what is challenging though, is that I spend an awful lot of my time interviewing, and trying to hire and fill some of these holes. And, you know, I feel like, I do feel like, you know, as an agency, we are making good progress. I feel like we have good people, you know, the people that are currently our leadership team is great. And, you know, I think we've really got some positive things ahead of us, but we've got to take care of ourselves and each other along the way, you know, very much so. So I was very appreciative. Thank you.
Thank you for sharing that. Yeah.
Point I want to bring up again is I think why we're so at risk for burnout is because if you think about what our product is as a clinician, you know, I bring up this, I made a joke once, Ford builds trucks, Root Center, it's our clinicians. I always talk about 70 to 80% of a client's treatment success is built off the therapeutic alliance they build with their client. And that's a very fancy way of saying a trusting relationship. And that takes an emotional toll. I only have so much emotional energy to give in a day. And when I'm giving back to my staff and my clients, even if I'm not burnt out, I'm exhausted by the end of my day just because of how much of myself I give when I'm really doing the work. So I think as administrators, it's up to me to help my clinicians stay charged up enough and well enough so that they can keep giving back to their clients and to each other, because we are the product for Root Center. So thank you.
I think that's such a great point. Here, there's been a lot of talk about RVUs, and I think administrators here are sort of wondering, why can't your psychologist see as many patients as your APRNs can see? And, you know, we're doing a lot of educating them on what is psychotherapy and why is it that we can't do, you know, 15 30-minute appointments in a day, and why is it so exhausting to see 8 patients in a day, you know, for therapy? And it's just, it's different work. And I think that really speaks to your point about we're in the business of building relationships, and that's just qualitatively different than anything else in medicine.
I have to step out to another meeting, Cassandra, but I just wanted to say thank you again. I appreciate it.
Thank you. Thank you for coming. I appreciate everyone who took the time to be here today. I too will often do other things while I'm listening to grand rounds. I could totally relate to that. So I very much appreciate everyone who came today, and thank you for talking with me. And hopefully we can, you know, validate ourselves a little bit more and maybe figure out what are some next steps we can take individually and organizationally to make things a little bit more workable for ourselves.